Wonderful. All right. So I appreciate you all being here and for being invited to speak to you today about suicide awareness when working with college age participants. So, a really appropriate topic right now, as we're just a couple days away from going into Suicide Prevention Awareness Month here for September. So, we will talk a little bit about suicide awareness first, and then move into this a little bit more specifically with individuals who might be experiencing first episode psychosis. So, a little bit about my background. I am a licensed professional clinical counselor with a supervisory designation here in Ohio. I have about 10 years experience of clinical practice, primarily working with college students and at college counseling centers and in private practice. And now I took a little bit of break from clinical practice and I'm working in prevention with the Ohio Program for Campus Safety and Mental Health. And I'll go on to describe that program here in just a moment. So, some of what we're going to go over today is understanding the prevalence of suicide and first episode psychosis in college age individuals, and then understanding and identifying the importance of academic supports for college age individuals who are experiencing first episode psychosis. So, as I mentioned, I'm working in prevention now. I am with the Ohio Program for Campus Safety and Mental Health, and we are one of the three coordinating centers of excellence here at NEOMED. So, I will talk on the next slide a little bit more about what we do as part of this program. So, we were founded after the very tragic and unfortunate event in 2007 that happened with the Virginia Tech shooting. We received funding in 2009 to provide CIT training for university police and security officers. And from there, we continue to expand with receiving Garrett Lee Smith funding. It was the first time that this was ever provided to a statewide initiative, and we have just continued to grow from here. So, the Ohio Program for Campus Safety and Mental Health, in a nutshell, we work with all of the public and not-for-profit colleges and universities in the state of Ohio. And from the different states that we have collaborated with, this seems very unique to Ohio. It doesn't seem like other states have a program like this in place where they provide mental health and suicide prevention support to colleges and universities. So we don't provide any direct support or counseling to these universities. We offer training, technical assistance, and we offer mini grants as well. So colleges and universities can continue to offer mental health and suicide prevention programming. So that's just a little brief description of what we do here at OPCSMH. So, although a lot of you may know safe language when discussing suicide, I think it's important to take a little bit of a little moment here to have a refresher, because I know sometimes best practices regarding language with suicide, these change and evolve. So, for example, when I was training to become a clinician, it was recommended to say completed suicide rather than committed suicide. Now it's not recommended to say completed suicide either. So, a little refresher on maybe some updated language that can be particularly helpful for us to be aware of, not only moving into Suicide Prevention Awareness Month, but just moving forward in the work that we do. So, we'll go through just a few of these for sake of time. Instead of saying an unsuccessful suicide, which kind of implies that there might be like a desired outcome, we prefer using more neutral language, such as a suicide attempt or a non-fatal attempt or just attempted suicide. Really, same with saying successful suicide. Again, kind of implies that there might be a desired outcome. So instead of saying that, we recommend just saying that the person did take their own life or they died by suicide. As I just mentioned a moment ago, it is not recommended to say committed or completed suicide anymore. And rather, we're suggesting you use the language took their own life or died by suicide. So committed, I think we have known this for a little while, but that kind of implies this moral or even legal connotation that it's a crime or even a moral failing. Suicide victim, instead we recommend saying person who died by suicide. We really want to try to not define someone by their experience or their actions. Same goes for when we're discussing people who are experiencing first episode psychosis or schizophrenia. We don't want to define people by their experiences or their diagnosis. And then I'm going to jump ahead. We really don't recommend describing people experiencing suicidal symptoms or ideation as being manipulative or attention seeking. I hear that one a whole lot from clinicians and providers. Really, what we would prefer is just describing the actual behavior, or what I recommend is maybe even just saying the person is help seeking rather than attention seeking. They're help seeking. They might be reaching out, trying to ask for help. They might not know another way to do so. So that's just a brief refresher here on some language. So because this is the primary population we work with, and you might not be as familiar with the prevalence rates of youth and young adults, I wanted to take a couple moments here to provide you a little bit of information. So it's estimated that approximately 12% of young adults, those ages 18 to 25, have reported that they've experienced serious thoughts about suicide in the past year. And we know that for some time now, suicide is the second leading cause of death for college-age students. About 2% of young adults ages 18 to 25 in the US report a suicide attempt in the past year. And it's also the second leading cause of death among youth ages 10 to 14, and the third leading cause of death for youth around ages 15 to 24. And then from the JED Foundation, a recent report stated that the US average suicide rate for individuals 14 to 24 was about 15.2 per 100,000 people in 2021. So this is really important just to give us an idea of how suicide is impacting college-age students. In general, it's also estimated for that every one suicide, approximately 135 people are impacted by that one death. So this really impacts more people than just the person that died by suicide. So I know this is a lot to swallow, some tough statistics to hear, but I do also want to share that in the past 3 years, sorry, we have actually seen rates declining in suicide, particularly for college-age students. So a lot of the work that we're out there doing is effective. It's paying off. We are seeing declining rates, and we have more work to continue to do. So I pulled some information here from the Healthy Mind Survey. So the Healthy Mind Survey is an annual survey that examines the mental health and well-being of college students specifically. Approximately 450 colleges and universities across the US participate in this survey. And this report is from the 2023-2024 academic year. And to show just some statistics here, and something that we know with first episode psychosis is that there is the comorbidity of experiencing depressive symptoms. So here it's pointing out that approximately 19% of college students reporting some serious or severe depressive symptoms, and about 38% report moderate or severe depressive symptoms. And about 13 have reported suicidal ideation in the past year. So this is just also pointing out some more specific statistics about this demographic. And then some more statistics here for you to see as well. As I mentioned, about 13% reported suicidal ideation in the past year, 6% reporting a plan, 2% had a suicide attempt, and about 26% are engaging in non-suicidal self-injury in the past year. So moving forward here, they also ask college students if they've ever been diagnosed by one of the following conditions by a health professional. And jumping ahead to look at psychosis, only about 1% of individuals reported being diagnosed with psychosis. But that makes sense when we think about first episode psychosis, because the emerging age or the age of onset is going to be around college time. So students might not really be aware of what they're experiencing yet to have received a diagnosis. But we do see people reporting other symptoms like depression, or other diagnoses, I should say, like depression, anxiety, or even trauma. So I anticipate that, if they surveyed students more specifically, looking at maybe freshmen versus seniors or graduate students, there might be more or higher rates of diagnosis of psychosis or even schizophrenia because of that age of onset. So another myth that is very common out there is that suicide almost always occurs without any warnings or signs. And while sometimes it can seem like that, and we do know that sometimes it's really the happiest people or the people we always see smiling who end up dying by suicide, there are also warning signs and symptoms of suicide. So I think it's really important that we talk about what some of those are and what some of those are specific to these college age students, what we might see. So I'm not going to talk about all of these, but I do want to point out a few of the common indicators that we might see among college age students that might suggest that this person is suicidal. And not only suicidal, but I think some of these indicators can also just suggest that they're experiencing some type of mental health concern or crisis as well. So worsening school performance, that's a really big one. Student might have been previously performing really well, and then we see a drastic decline in their grades, their performance, maybe even their attendance. Some unhealthy peer relationships, neglecting hygiene and appearance, social withdrawal, that's a big one that indicates maybe risk for suicide. Previous suicide attempts or even family history, we know not only for college students, but for individuals across the board, that can be a warning sign of potential suicidal ideation. Changes in eating and sleeping behaviors, breakups or other major relationship losses, that can be something in particular we see being a big maybe trigger or something leading to suicidal ideation for college students. And lack of access to mental health care. I think that's another really big one. While colleges and universities do offer counseling on campuses, some of these campuses that have limited supports. They might only offer 6 free counseling sessions for students, and then students might feel stuck of where to go from there. They might not have healthcare or insurance coverage to seek additional support off campus. Or, in my experience in private practice, some students have just been referred out or off campus. Of their campus counseling center has said, what you're presenting with is too high risk for what we work with here, and we're going to refer you out. We're going to refer you to somewhere off campus. So that can be another big concern. So some things that we might hear when someone might be considering suicide, because more often than not, people don't come straight forward and say, hey, I'm suicidal, or hey, I think I'm thinking about killing myself. They might give us more indirect clues. They might say things like, nobody cares, or I wish I were dead. Soon you won't have to worry about me. Everyone will be better off without me. So again, some of these things that may sound a bit cryptic, they might be more indirect. And we might have to do a little bit more digging to find out what's underneath the meaning of this message, what's actually going on for them. So, just because someone doesn't directly come forward and tell us that they're suicidal, it's still our responsibility to dig a little bit further, and make sure that this isn't something that they're experiencing. So suicide, more specific to individuals experiencing first episode psychosis. First, we're going to talk about schizophrenia in general. So suicide is among the leading causes of death for individuals with schizophrenia spectrum and other psychotic disorders. Approximately 40 to 50% of individuals diagnosed with schizophrenia experience suicidal thoughts, and 20 to 50% make suicide attempts, and it's estimated that 4 to 13% might die by suicide. So again, high rates here are something that we really need to consider. And another statistic here to really, just show the importance of this. Suicide remains a significant concern for individuals experiencing first episode psychosis, particularly within the first year, where the risk is elevated by 60% compared to later stages of the illness. So this really is indicating that when individuals are experiencing first episode psychosis, we need to be particularly mindful of assessing for suicide and treating for suicidal ideation. It's also estimated that about 40% of young adults with first episode psychosis report thoughts of suicide. About 31% attempt suicide. And among the same group, about 53% report experiencing significant stigma and prejudice, and about 50% report experiencing social exclusion. So even, the stigma, prejudice, social exclusion, those can be kind of even worsening some of the suicidal ideation or suicidal thoughts as well as risk factors. So getting a little bit more into the academic impairment piece. So this statistic here, also from Healthy Minds, is showing that individuals who experience some type of emotional or mental health difficulties do experience impact to their academic performance. And this is important to know because with first episode psychosis in particular, it's kind of a bi-directional relationship. Stress can trigger and exacerbate symptoms of psychosis, but also the stress that the student experiences based on their symptoms might also worsen their school performance too. So they can be impact. It's like chicken or the egg, which is impacting the other. And this is important to pay attention to because educational attainment is often tied to better health and overall outcomes for college-age students experiencing first episode psychosis. So making sure that we can provide some supports to individuals in college when they're experiencing first episode psychosis to help them be as successful as possible. So I'm going to talk about those in just a moment here. So I wanted to just share this quote here, which I think really strengthens the message of what individuals can be experiencing when they're experiencing first episode psychosis and in college. So this says, "It's very difficult to describe the changes I started to experience, but overall, everything suddenly felt very different. The world looked different, my hands felt different, I felt confused by my own thoughts, and had much more trouble following what professors were saying in class. But nothing obvious like hallucinations. When I first told a campus counselor about this, she said I probably just needed more sleep. If she had connected the dots, I would have gotten help about 6 months sooner." So again, just really reiterating the importance of this and the lived experience of one specific person who was in college experiencing first episode psychosis. So there is help and that means there is hope. So we're going to talk just briefly here about some of the supports available. Of course, there's individual placement and support, and the best center, that's really what they talk about, is the importance of an integrated and a team approach, knowing that early intervention is key, and they're the department that can help you in particular with coordinated specialty care. Then we recommend peer support. So things like Active Minds. Danelle, earlier you were just talking about NAMI, or maybe even specifically NAMI on campus. Those are supports that we can get students connected with. Then, of course, with students' permission, we can coordinate directly with the institution of higher education. So one of the things we can do in working with a student is attend to some safety concerns, creating safety plans, making sure we're including maybe allies or other advocates who are on campus to help if anything goes awry. We can work with care teams directly on campus. These are oftentimes the first responders or the individuals on campus who will reach out to students if they have some type of indication of a safety concern. We can work directly with the campus and student accessibility services for a variety of different accessibility adjustments that we can potentially make. And oftentimes students don't know about these, and even off-campus providers don't know about the type of supports that are available. So for example, we can connect with resident services in requesting private rooms for students, or even preferential living spaces and locations. Making academic adjustments in the classroom to help when there might be onset of symptoms like depression, anxiety, fatigue, mental cloudiness. That could be extended test taking time, that can be extended submission or deadlines for assignments as well. There can also be some type of accommodations with registration or even financial aid. So allowing students to register early for courses, allowing them to just receive a pass or fail instead of a letter grade in a class, even allowing a refund after the refund deadline, so providing an extension on that deadline. Academic advising support, so maybe permission to request to work with specific advisors, maybe even allowing specific requests for internship placement sites. In the classroom, it might be things like allowing them to work on assignments individually rather than working in groups. And then we talked about flexible extensions and test taking as well. And then I wanted to mention about spreading awareness. So this is something that we really focus at OPCSMH, the importance of campus community collaboration. So for those who are working in the community, we encourage them becoming more involved on campuses and spreading awareness about mental health and suicide prevention. And in this case, first episode psychosis. So we do offer mini grants, as I mentioned before, and this allows collaboration between campus community partnerships. So it might be an organization such as Coleman might work with Kent State University in putting programming together specifically for suicide prevention. In my time here, I have not seen anything specific to first episode psychosis. So I think that could be a really wonderful opportunity to maybe put in a submission or a proposal for a grant to work with a campus to spread awareness and bring more support to universities and campuses on first episode psychosis. So I can drop our link in the chat if anyone is interested in putting a proposal together. Our grant period does close on September 8th, so it's coming up right around the corner. And I would be happy to answer any questions that anyone has about those as well. So that's another way that we can do our part to try to provide more supports to college students. And then just here's some contact information for how to get more in touch with the Ohio Program for Campus Safety and Mental Health. And because this was a tough subject today, just providing you some reminders of contact lines, the 988 text or call or chat line, and then of course, 741-741. You could text for HOPE if you needed any support. So I am going to wrap up there because I know I already extended beyond my time, but I appreciate you all listening and being here today.